Okay, I'm back. Good evening, everybody. Before we actually start this recording, thank you to everyone who's already joined the call. The registration link will only open at 6:30, so you won't be able to use the registration forms yet. Also, just to let you ask that you please mute your mics and stay on mute. This is going to be a recorded presentation. I've already done the recording, although the slides will precede those. The recording cannot be interrupted. So if your mics are on open and you don't mute your mic, you will be removed to the waiting room and then removed from the call. I apologize for this, but we can't have a lot of noise in the background because the speaker can't pause because we're running a recording. Professor Barodi is not on the call yet. I last spoke to him at midnight his time, and it's now 3:30 a.m. his time. I will phone him towards the end of the recording, and he will then come onto the call to answer questions. And we will also have Dr. Nasser Syed coming onto the call. I am aware that for those who are fasting at the moment, it is iftar. Ramadan started on Tuesday, I think. So we may have some people coming onto the call late, but those people have seen the recording and they will be able to answer questions. So welcome everybody to this call. Just a reminder, if you're tempted to unmute your mic, you will be removed from the call. It is 18:31 now, and I think we should start. So the first thing I'm going, to do is to introduce the concept. Let's just see if my slides aren't moving. So my name's Dr. Jackie Stone. I am the medical director and clinical lead for innovation and research for Infectious campus. And we've had a series of very interesting discussions, and one of the lines that we're following is infectious disease and combination therapy in infectious disease. And those are my qualifications. My bio is will take too long. So I'd like to move on. We will do Professor Barodi's bio a little bit later. All of his bio is in the SADC groups. And for those of you who haven't heard of him, if you Google him, you will get several versions of his extensive bio. He's got 3 PhDs, a medical degree, and half of a law degree, which he got bored with and switched to medicine. So we're very, very privileged and honored to have him tonight. I'd like to reiterate the themes for Intellectus Campus. We've discussed constructive controversy, and the biggest benefit of constructive controversy and open debate is it leads to better decision-making and problem-solving than you might have through consensus, debate, or individual effort, and it helps protect us from blind spots. You will hear some things tonight that are as a result of a dialogue and people thinking on their feet. I hope you enjoy it, and I hope it generates some significant discussion. Our other theme is that we need African solutions for African problems according to our resources and our experience and our demographics. So the learning objective is, the first one is to ensure that the first therapy is the last therapy. You want to treat once, otherwise you will promote resistance. And we've said before on other forums, hit it hard, hit it early, hit it with combination therapy if it is an intracellular organism. The definition of insanity is to do the same thing over and over again and expect a different result. That's, according to Einstein. Professor Barodi's version of this is the definition of insanity is to use the therapy again that didn't work the last time. And hopefully this will encourage many of you to treat Helicobacter for longer with stuff that it is not already resistant to, and also to not halt therapy too early and to ensure that you use the right combinations. This is also a safe environment for which Africa and Australia can discuss this all openly. We've been through the chain of infection in the past. We last dealt with the portal of entry with waterborne diseases. This time we're going to focus on the infectious agent, and after this we will also be going through several other infectious diseases, including TB and leprosy, which is often forgotten in the differential diagnosis. So April is Infectious Disease Month, and this is the opening ceremony of Infectious Disease Month, basically getting us to think about how we avoid antimicrobial resistance. In terms of the portal of entry, we're going to be focusing today on the gastrointestinal system. I've showed this slide before. Semmelweis was the person who said, wash your hands. There is a tragic story of this doctor. Not all heroes wear capes. This one from Hungary wore scrubs, and he was known as the savior of mothers. He was incarcerated at the age of 47 because nobody could explain in 1865 why people who were going from the morgue to the delivery suite were causing sepsis. Pride, please remove anyone who's unmuted off the call. And so Semmelweis went into an institution of having been telling doctors since 1847 to wash their hands, but until Pasteur showed that microbes existed, nobody actually believed him. He died, ironically, from sepsis in a mental institution for advocating that doctors wash their hands, and may his soul rest in peace. So the Semmelweis reflex is the invincible, sorry, I've got a bar across my screen, so I can't read my slides, but it basically describes that doctors will not change their minds, even when new knowledge seems to contradict our current beliefs. So current beliefs trump new knowledge. What I hope you understand in this talk is to know your enemy, whether it is Helicobacter or any other infectious disease. The savior of ulcer patients from surgeons was Professor Thomas Borody, or is Professor Thomas Borody, and he is very much still alive and kicking. And his groundbreaking work saved hundreds of thousands of lives and resulted in substantial cost savings for the Australian health system, over 10 billion in medical care. So we've emphasized teamwork before, and the only way we can win and beat infectious disease is as a team and to stay ahead of it. And our current state needs to transfer to our future state. And we need, if we have the knowledge, we need to go to strategy, execution, and then evaluate our results. And with that, I am going to stop sharing. And Pride, can you please play the recording? If you can't play it, I've got a copy of it. Good evening, everyone, and welcome to another session of Intellectus Campus in our series on infectious disease and combination therapy. So the title tonight is anything new in Helicobacter? And we're very, very privileged tonight to have Professor Thomas Borody, who I've just found out has 3 doctorates. So he's a real doctor times 3. He's also trained in law and in medicine, and probably a few other things as well. And in the days where I was still a medical student, he was very famous for being part of the team that found the cause for ulcers, which was Helicobacter, and also discovered the treatment for it. And the team won a Nobel Prize in 2005, if I'm correct. Professor Borody, is that right?
That's correct.
Cool. So we're very, very honored to have you tonight, and I'm very grateful. I'm not going to read out your extended bio in this recording because we'll do that on the group. We'll put it onto the group in the interests of time. I think most people know who you are. So without further ado, we've had a bit of a discussion about Helicobacter as it is in Australia at the moment. In Africa and in Zimbabwe in particular, 70% of our population are Helicobacter positive. So we are nowhere close to what you have achieved. And at the same time, we are seeing resistant Helicobacter because of people taking what we call a pylori pack and not finishing the course. So I'd love to hear your views on Helicobacter. I'd love to hear your views on the need for combination therapy to kill organisms that are intracellular, and what we do about resistance. And I'll give you the floor, and then from there, I've got a couple of questions at the end. Thanks, Prof.
Well, thank you, Dr. Stone. I developed an interest in Helicobacter when I came back from the Mayo Clinic in '83, and there were noises out there that there is a thing called Helicobacter. It wasn't called that then. It was called Campylobacter pyloridis, named by one of our microbiology professors, Adrian Lee. And then it became Campylobacter pylori. And then when the genetic structures were worked out, it got a new name, Helicobacter, and that's what it has remained, as the name has remained that. Now, we started looking for Helicobacter. I'll use the last name from now on. When I started endoscoping patients when I came back from the Mayo Clinic, and that was 1983. And we set up our own little mini Mayo Clinic. We now have 62 staff. We're the biggest gastroenterology unit in this country. And we used to see a lot of ulcers. And if you just remember that when we endoscope patients, we would endoscope top end, we might see 15 and the rest of it's colonoscopies. But on a daily basis, I would see 3 ulcers per day. It was that common. We had stricturing duodenum. We had patients who had such strictures that the stomach distended and they'd be vomiting every now and again. And Helicobacter grows in gastric mucosa, stomach lining. It doesn't grow in the duodenum unless you have a patch of stomach lining called gastric metaplasia. And wherever there's gastric lining, in Meckel's diverticulum, even in the rectum, and a person has an infection with Helicobacter, you'll find it there as well. So it became a challenge. It was pretty obvious. Here is the bug. We ended up culturing it, and it's sensitive to amoxicillin in a culture plate, like they're virtually all sensitive to amoxicillin. So what did we do? We gave patients an amoxicillin treatment. And what happened? About 14% got cured. Why 14? Why not everybody? When you have a urine infection, you cure virtually everybody, provided they take it long enough and drink enough water. But one antibiotic, and then the penny dropped. Helicobacter is not an extracellular infection alone. We've demonstrated when a gentleman here did his PhD with us and did electron microscopy, and it was shown that is both intracellular, like tuberculosis or leprosy, and extracellular. All viral infections, for example, are intracellular. And then the penny dropped, for we understood that intracellular infections, like tuberculosis, you have to use multiple drugs to block enzymes both in the both in the cell of the stomach, but also in the mucous lining. And antibiotics don't work very well when there is acid present. So we developed the first triple therapy back in 1984. And I always ask people, what were you doing in 1984? And many of them say, I was in primary school, you know. And so we would treat people, and we treated over 34,000 patients progressively. And initially, we experimented with various combinations of already approved medications. And we found that what gave us a 96% cure rate is when we added amoxicillin, for example, or tetracycline. We used metronidazole, we used bismuth, and we ended up with the first treatment, which is still on the market, called Helidac, which is bismuth, tetracycline, and flagyl. And flagyl, there is resistance to, but if you combine it with other antibiotics, the resistance of metronidazole is not that important. However, one always strives to have the first therapy as the last therapy. And I'd like to underline that because it's one thing catching the flu, and you can catch it again and again. But with Helicobacter, once you've eradicated it, it's rare to catch it again. It's an unusual situation. There is some form of an immunity that's present, both cellular and circulating, that prevents further infections. So we then were using bismuth, tetracycline, and flagyl, and there was a lot of interest early on in Germany and in the AMC, the Amsterdam Medical Center. Guido Titgat was interested, and we started doing some work with the British. And in the US, there were several people who were interested in Helicobacter, David Graham, for example. And he didn't believe it initially. That was all quite interesting. We had discussions for years. But finally, he became a big supporter when he did his trial in Texas. So we developed triple therapy, and we had a standard treatment, but we noticed that some patients who either didn't take the whole treatment or missed tablets or developed an allergy halfway through and they couldn't continue, they came back positive when we did the breath test, because we developed a urea breath test fairly soon afterwards, so we didn't have to endoscope a second time at 6 to 8 weeks. So the treatment would be, say, 10 or 14 days. Then you leave 4 weeks without any treatment, because if it's still there, it takes weeks and weeks to grow up to a number that you can then retest and see if it's there or not. If after 10 days you go in the stomach and take biopsies, you will not find Helicobacter, even though it is there. And especially if you have intestinal metaplasia, which is intestine mucosa growing in a stomach, which is often driven by the chronic presence of Helicobacter, you cannot find Helicobacter even though it is there in small numbers. And that's an important finding because it goes on to develop stomach cancer, going from dysplasia to carcinoma in situ to cancer. So our first developed product was triple therapy. That's where it got its name from. Triple therapy of bismuth, tetracycline, and flagyl. And then we thought, well, why don't we put it all into single tablet? So we also noticed that if you add a proton pump inhibitor, which makes the pH go up because it's an acid blocker, the antibiotics work better, and patients feel better because they often have coexisting reflux, and they eradicated so much better. And then I did some studies. That was my first PhD. Did some studies to show that in a stomach of a person, if you culture around a number of areas like a map, you may have 3, 4, up to 10 Helicobacters with different culture sensitivities, which says something about, well, why don't you just culture it and find what it's sensitive to? You can do that with urine, but it's more difficult with the stomach. If you're lucky to hit the predominant strain, yes, it'll help you. We don't routinely culture unless we have intestinal metaplasia, and then I use 5 different tests in every patient with resistant strains. We do urease test, histology, culture, urea breath test, and sometimes stool test. Because in the area where I treat, patients fly in from overseas to be treated because they cannot get rid of the bug. And the mother may have had stomach cancer. They don't want to have a carcinogen sitting in the stomach. And Helicobacter has been pronounced a class 1 carcinogen, very similar to smoking. So it's like your stomach is smoking all your life. You acquire it usually in childhood or first year of life. Then it stays with you and it causes white cells to invade called neutrophils. Lymphocytes are always there, and you have active chronic gastritis. If you get rid of the Helicobacter, inflammation settles, the neutrophils disappear, and you remain with lymphocytes. And a histology can be shown to be doing this by about week 6. So then we started producing a single capsule, and I had companies involved in this to try and manufacture it. So Axcan Pharma obtained the rights, and we produced Pylera. And Pylera was acquired by Leon Goselin's Axcan Pharma in Mont-Saint-Hilaire over in Montreal. and it's still on the market, called Pylera, Pylera. And so that dominated the market to a certain extent. And there were some copies where they would use double therapy. That didn't work very well. And the latest one, which we've developed, which is now on the US market, is Talisha, Talisha. So Talisha is different because it contains rifabutin. And rifabutin plus amoxicillin plus omeprazole gives you omeprazole, which is inhibitory to growth in the culture plate to Helicobacter. Rifabutin is one of the best ones. There's no resistance to it as there is with amoxicillin. And so it is the highest, most effective real-life study anti-Helicobacter therapy. And we questioned initially whether you may not develop resistance, because after all the rifamycins, ansamycins, rifampicin, rifapentin, and rifabutin are used for the treatment of tuberculosis. Well, we have done don't have much tuberculosis here, and if you eradicate the infection, we won't develop resistance in Helicobacter. So it is okay for countries with low level of infection of tuberculosis and leprosy, because we do use those things. Now, we now have 3 of the products, Helidac, Pylera, and Talisha, on the US market. So that is the old. There's 2 classes of Helicobacter. The ones that have been eradicated, they're gone. And then come the resistant strains. And I'm always fascinated when I get a referral to treat a resistant strain, how a doctor may have given that patient up to 15 times given the same therapy, and it still fails. As soon as you fail the first time, it's a problematic infection. And as you know, the definition of stupidity is to use again the therapy that failed last time and expect a different result. So as soon as we fail a combination, we use specialized combinations second time round, and we have a whole list of those. But what has emerged recently is a new acid suppressant called a potassium channel blocker, or PCABs they're called. And the most outstanding of these 5 drugs is vonoprazan. It's a bit more expensive, but you're taking it for 10 days. And like proton pump inhibitors, when I actually suck up liquid in the stomach, and the untreated stomach will have a pH of between 0 and 1. But if you put someone on proton pump inhibitors, and they took it that morning before they're being endoscoped, your pH will go up to about 3, 4 at most. It doesn't make the gastric acid go away completely. What does is vonoprazan. And vonoprazan within 4 or 5 hours will raise the pH to that of water, which is 7. And the higher the pH, the better the antibiotics work. And so we use now vonoprazan together with, that's the pH riser. It has no antibiotic activity. Vonoprazan, rifabutin, and amoxicillin. And so you do not develop resistance. And in those who are treatment naive, never had a treatment before, we get, with last count, 44 out of 44 patients were cured. It approaches 100%. Nothing else comes close to that. And it's easy to take, turns off the acid if you have reflux at the same time, and you feel good because of vonoprazan. If you look, we published in Helicobacter 157 cases. They were treated at least twice and up to 15. Then we got a 94% cure rate. So then if someone fails 3 times, and I have a patient now who's failed like 7 times, and I'm constructing a special for him, you then have to add other active agents. And so bismuth subsalicylate or subcitrate we use is the useful medication because it is bactericidal on Helicobacter, forms complexes on the wall, inhibits different enzymes, and it prevents adherence in the mucus layer to the epithelial cells. So you can add that. You can add tetracycline. We don't use levofloxacin. It develops resistance quickly and patients get adverse effects. There's the word for it, I've been floxed. So the second run of treatment, we usually add bismuth or tetracycline or bismuth, and we have an enzyme sometimes that we use from Japan, Prozyme, and that dissolves the mucus. There's a few things in the pipeline which I can't speak about at this stage because we haven't got data, but this is the group of patients that I see mostly because they get referred from referring doctors with a problem of we treated them with what's called Nexium HP7, which is esomeprazole, amoxicillin, and clarithromycin, which should never be used ever again. The reason is the clarithromycin resistance is so common. The eradication rate in Australia is around 65%. The sort of world writing expert on this is David Graham, Texas. He runs the journal Helicobacter. We're very good friends. And he is very strong on making statements in various papers that gastroenterologists should never use a combination of clarithromycin, proton pump inhibitor, and amoxicillin. So the resistant ones, we start off by using vonoprazan, amoxil, and rifabutin. And we break the rules by going 4 times a day to try and get the blood levels in the mucus layer to be high so that the bacteria won't develop resistance. If you got a resistant, then we could add, I mentioned 2 drugs. You can add that. You can sometimes add nitazoxanide and bismuth tetracycline. So you may have to have 5 drugs. There's a Japanese group that actually puts a nasogastric tube in and actually washes the stomach out with various anti-helicobacter chemicals, mucus-dissolving agents. They only get about 80% because they don't have a balloon blocker in the duodenum to prevent the liquid going down the small bowel, and you then get side effects, man. So I've never used that. We are in the process of making a nasogastric balloon blocked tube. So that's this sort of latest thing. Now, helicobacters are not just Helicobacter pylori. There's nearly 30 of them. You can find them in bile. You can find them in pancreas, in the liver. But for the stomach, which is where gastrologists travel every day with their endoscope, not urease positive, very minor urease production. It can be eradicated with same drugs, but you cannot do a breath test on it because it doesn't produce urea positive tests. So you got to rescope the patients to multiple histologies and cultures. So if I get sent to Helmani, and it's much more tighter looking under a microscope, like a tight corkscrew versus an open corkscrew, which is Helicobacter pylori. So that's the only other small thing. And many places don't diagnose it unless you do biopsies. Because the urea breath test will miss Helmani. And they still develop ulcers. They still go on to stomach cancer in a small percentage of people. China was the big place of Helicobacter associated stomach cancer. And I think I've traveled to China talking about Helicobacter eradication maybe half a dozen times to the various Ings, Beijing, Nanjing, into Shanghai, Hong Kong as well. So it is a national problem. Japan is the same, very high level of stomach cancers. And we had lectures there translated with a little device on the ear, how to eradicate non-resistant and resistant Helicobacters. So that covers what I wanted to say. And Jackie, did you have any questions that you would like to ask?
I've got lots and lots of questions, but I am aware of the time it is in Australia right now. So the first thing I'd like to say is in 1984, I was first year medical school. And I think it was also famous for George Orwell's book. So 1984 was a good year, as you might say. We have a very different demographic to you. We lose 400 people a month to TB, including children. Many of them have HIV. We still have leprosy in our differential diagnosis. And I know that we will get pushback if we start suggesting to use RIF anything, rifabutin, rifapentin, rifamycin for Helicobacter. Having said that, as a bit of a out-the-box thinker, we've got a multi-drug resistant TB problem, which also requires combination therapy because you also need multiple lines of drug. We've known since the early 1980s that you can't treat TB with monotherapy. So one would have to ask the question, if we were to treat the 70% of our population with Helicobacter, with rifabutin, amoxicillin, and with omeprazole, would we contain TB? And that just came to my mind when you were talking. Would it be a strategy that could...
So what you're asking for is how to design an effective therapy excluding rifabutin or rifa anything, right?
Sorry, you broke up for a second there. I think it's the connection.
The idea that you've got is how to design a combination therapy for, say, Zimbabwe, Africa, which would exclude the presence of rifabutin, but still give you high efficacy.
That's one question. The second question is if that we were to include rifabutin in our Helicobacter treatment protocol, and if 70% of our population are Helicobacter positive, would we not eliminate the TB problem?
Don't use it because you don't know who may be carrying early tuberculosis. And that's the one that'll develop resistance.
Okay. So that's an important lesson for us. So given that we have a lot of tuberculosis around and a lot of immunocompromised patients, we've got about 1.4 to 1.5 million people with HIV, living with HIV on ARVs. So what would you recommend to a place that does have TB and leprosy and that is under-resourced? So omeprazole is off patent now. So we have generic omeprazole available, and it would be a lot more affordable in bulk to our standard population. So what would you suggest? You've said no to clarithromycin, and we have seen resistance to it. Metronidazole, the side effects are quite significant in my experience here. And metronidazole. So what would you suggest as a regime in Africa, and for how long would you suggest people use it? Because a lot of doctors will treat for 10 days to 2 weeks here because they want to treat it once. They don't want to give a 7-day course and then be faced with a resistant organism. So I'd love to hear your comments on what you think we could do in Africa, because I know you have time in the Solomon Islands as a solo doctor, so you can relate to a lot of us out in the boondocks in Africa.
Well, remember when I was in Solomon's, I was treating different infections, and Helicobacter wasn't known in Australia, America, because I was there in 1978. A 200-bed hospital, one patient, 80,000 people on Malaita. So I learned dentistry instead. I had to be a dentist. You had to, because you had to deal with everything. I had to open heads to remove subdural hematomas. If a coconut fell, my Marjolin's ulcers on the legs had to amputate sometimes, so you got a different experience. But let's go back to Africa now, Helicobacter. The other thing I'd like to mention is that Helicobacter was not discovered by our Australians. It was discovered in the Jagiellonian University, 1896, by Valery Jaworski, place where I was born in Krakow in Poland. And he saw these spiral bacteria, which he aspirated through a nasogastric tube. And he named them Vibrio rucola. I've got that in his book, but it was written in Polish. So I can read the language, but Marshall, my mate Marshall and Robin Warren, they didn't. So you couldn't search it very easily when they were working on this. And he wanted to know, of course, what's it associated with? How come patients have pain? What is the pain caused by? Is it an ulcer or is it a stomach cancer? So he came across barium because it's a metal that you can swallow as a liquid, but he had no ability to do a Röntgen, as they call it over the X-ray. So he got on a train and went to his friend in Warsaw. Her name was Marie Curie Skłodowska. And she gave him radium. He did X-rays. And he developed these X-rays having got barium swallows. And it's just fascinating how innovative he was. He was doing this in sort of 1900 and 102. She got 2 Nobel Prizes, but of course women in those days were not allowed to get Nobel Prizes, so her husband had to collect them. And she got one in physics and one in chemistry. So Marie Curie was associated with Jaworski, and he's the one who invented the bug. Also, the combination therapy, I was not the first. The first was 1956, Lykoudis in Greece. He was a doctor 12 kilometers away from Athens who had chronic diarrhea. And and an ulcer. He was so sick and tired of this chronic diarrhea. He took all the known antibiotics back there in 56 and he got rid of his diarrhea, but his ulcer went away. And I'm serious. He treated, it's all written up in the book. He treated a lot of Greek people who there is again a higher incidence of Helicobacter by using the combination. Of course, he was fined by the courts for using drugs and deceiving people, but they all got to court and protested against the court people, against the judges for giving him a fine of 400 drachma. He was fined for helping people. It reminds me a bit like use of ivermectin in Australia, and you know that very well. So it was found by Jaworski. Multiple therapies were found, but useless now because those drugs don't exist. And I just came at the tail end of it. And retrospectively, I found out that Lykoudis actually did this work. His son wrote it up after he died when the Nobel Prize, which I wrote the application for Barry and Warren. And the Lykoudis story was written up in the Lancet by his son. So history in retrospect makes it easier for us to understand. So Marshall and Warren contributed most by swallowing the Helicobacter. That's their claim to fame, because they never used triple therapy, never published anything on my triple therapy. They're in Perth. We're about 3 hours away by flight to Sydney. Is that how long it takes to fly, Jackie?
It's about 4 hours. I've done it
4
off.
hours. Yeah. If you glide the last bit out of gasoline. So I think it's bismuth, tetracycline, omeprazole because it's cheaper. And instead of flagyl, use tinidazole rather than metronidazole. Because it doesn't give neuropathy. No cases are reported in children, only with metronidazole. And you need 4 different blockers to the reproduction. So if you've got resistance to one, you won't have resistance to all 3. Bismuth, you don't get resistance to. Tetracycline is rare. Omeprazole lifts the efficacy, but also is an antibiotic. So if you use 4 times a day omeprazole, as if it was an antibiotic, and you may use 40 or 60 milligrams. For the 14 days, and I would suggest 14 days, it won't hurt you to have a higher dose of omeprazole, but you're not using it to turn the acid off. You're using it as another antibiotic plus tinidazole. One could use nitazoxanide if one wanted to, but I wouldn't go there. I mean, it has very few side effects, but there are a number of medications that inhibit Helicobacter in culture. So that's my quad therapy, I'd call it, for Africa, to try and eradicate the infection for those who should not be using rifabutin because they'll have a small amount of TB in the upper zone somewhere, and lymph nodes are gone complex, and then you develop resistance.
So Tom, what dose of tetracycline would you use? Is doxycycline an option because we make
No.
doxy here?
Doxycycline we published doesn't work. It's absorbed in the duodenum. It's bypassed the stomach. You need it to open there in tetracycline hydrochloride, and you want at least 250 milligrams 4 times a day. It's tetracycline hydrochloride, not doxy. Doesn't work. We published it.
Okay,
It
that's
doesn't.
very useful.
Tetracycline
Okay.
hydrochloride. Whatever bismuth you can get, subcitrate, subsalicylate. I tend to use subsalicylate, and high dose of omeprazole, remembering you're not using it to turn off acid, but you're using it like an antibiotic. And tinidazole, maybe make it 4 times a day so you get a blood level 4 times a day, and 250 milligrams QID.
Okay. So with the omeprazole, when you refer to high dose, what would you call high dose omeprazole?
Well, if you want to cure a patient, its side effects are so minimal, I'd probably use 40 milligrams 4 times a day.
Oh,
But it
no,
doesn't hurt you. Your ears and hair won't fall off.
yeah, no. As you said, you asked me a question once why I
Yeah.
used high dose medication, and I said no, I don't use high dose medication. I just don't use low dose medication.
Well, if you want to eradicate not form resistance, you want to eradicate first time around. That's the important thing. David Graham always writes that. He's the guy from Texas who did not believe in Helicobacter. And
Okay.
then he did, and he became the front runner and set up the journal called Helicobacter, if you ever come across that. David Graham's the editor-in-chief. They're looking for a new one now. So Jackie, maybe you want an editorial position, take it.
No, thank you.
It's a
I
lot
think
of
I've got
work
quite enough on
involved.
my plate at the moment, and so do you. So,
So David flew aircraft in Vietnam War. He's been around.
oh, cool. Anything to do with AvMed, I'm keen on, and Helicobacter is not to do with AvMed yet. We aren't evacuating people. So in the 80s, when I did my surgical rotation, ulcers were taught by the Department of Surgery. And I very clearly remember this line of patients going in for surgical procedures,
Yeah.
having ulcers cut out, which clearly was after 1984. And it took a very long time for this to reach the mainstream, because I still remember in the 90s when I was working in London of Helicobacter not being mainstream. So can you talk us through a little bit about the sort of resistance that you encountered with Helicobacter and people accepting that it was the cause of ulcers, because it was also, there must have been pushback from the surgeons who were doing very well out of ulcer treatment with a scalpel?
That's an interesting question, because only retrospectively did I realize that there was not a lot of resistance, and that the reason was this, that even though I used to assist Mr. Tom Hugh, great surgeon, and we would do highly selective vagotomies on his operating day, highly selective vagotomy, and but these operations are now not known by surgeons because they're not needed, because no one's referred for chronic ulcers. They're gone. So the loss of that is not an issue. Now, I started treating these patients in 84, and because we had a clinic a standalone clinic where we endoscope patients, and we endoscope 5 times a day. Then we would treat them. Then we'd re-endoscope them. And guess who learned that it worked? The referring doctor. And the referring doctor would keep on referring anybody and everybody who had an ulcer. And soon the patients had told everybody else. And so the gastroenterologists cottoned onto it. And if they didn't want to lose business, they would treat as well. So there was no resistance anywhere near as much as there was, say, for coronavirus treatment. Well, that was resistance. That still is. But
Yeah.
there's a story about a young doctor who took over his father's practice when the father went on holidays for 6 weeks, 8 weeks. And father comes back, well, how did you go? And the son says, well, you know, Mr. Jones, you have treated him for 20 years for an ulcer. I cured him. He's cured of an ulcer. And his father said, why did you do that? He put you through medicine.
A patient cured is a customer lost. So,
Yeah.
so on the triple therapy side of things, I was working at St. Bartholomew's Hospital in London from about 94 onwards. And one of the things that was interesting when you talk about seeing that combination therapy worked, a couple of patients were coming in, and bear in mind, St. Bartholomew's Hospital drained Fleet Street in the Old Bailey. So we had some extremely well-informed patients coming in, and I was put very firmly in my place as a young, arrogant South African doctor when I told a patient what to do. And they said to me, darling, your job is not to tell me what to do. Your job is to give me my options. And he clearly knew more about his disease than I did. Okay. So I didn't go into outpatients again without reading the latest journal. But we one
mind you,
night had
there was no Dr. Google. There was no Dr. Google. They're even worse now because they come in with pieces of paper telling you what some person in South Africa is doing, you know. It's worse now.
No, it is worse. But these guys were pretty clued up. And one night I'm Zimbabwean, and then we had another Zimbabwean, but we were both trained in Cape Town, and an Irish doctor, all sitting around, and somebody very senior at the Old Bailey had severe cytomegalovirus infection with cytomegalovirus encephalitis. And he needed a central line, which we put in. And I'll tell you a bit more about that story another time. But we knew he wasn't going to survive the night. We gave him ganciclovir, but his immune system was finished. I think his CD4 count was about 7. And we decided that why not? At that stage, we had AZT, 3TC, and the protease inhibitors had just come out. And we knew we'd be in trouble. So each doctor wrote up one drug and signed it, pretending not to read the rest of the drug sheet. So we wouldn't get into trouble in the grand round because we were doing something that hadn't been done before.
Yeah.
And miraculously, the next morning, he was still alive. And everybody said, the ganciclovir is wonderful. And then on the grand round, about a week later, the prof looked at it and said, why is this guy on 3 drugs? And he looked at us, and we all went with our little halos above our heads. Oh, no, sorry, we just went and wrote up 1 each. And shortly after that, maybe 6 months after that, triple therapy became proven and given to everyone, and the death stopped. But interesting, this man who would have died that night in Smithfield, London, survived to get triple therapy. And he may well still be alive today. So I have always looked at combination therapy with, wow, I came from seeing 30 TB patients a day in the Eastern Cape in South Africa. And I couldn't understand why we were using high-dose monotherapy against HIV in the early days.
Yeah.
And once we started combining it, it was like, how did nobody do this in the early 80s when HIV was discovered? And it just seems that history in the 80s, it was TB. Helicobacter to follow, HIV to follow, and now coronavirus. When will we ever learn that you cannot use monotherapy for an intracellular organism? And
Like you,
that was
like
one of the
using
things that you taught me. And I
like
thank you for that.
molnupiravir, right? The single therapy molnupiravir.
We call it Mypiravir and we can't afford
No, but
it.
I'm just saying, why would you do a single anti-coronavirus? Why would you do a double like Paxlovid? So, I mean, we talk a lot and we use three, sometimes we use four. But I just want to go back to Helicobacter and tell you another story. It was in Hawaii, and I used to go there for one of these junket places trips for a holiday. It was January 1986, and I'm listening to the speaker talking to us about Tagamet, right? And I had to listen, and someone opens the back door and comes down this theater, which was sloping down to the front to the speaker. He gives a note to the speaker, and the speaker stands and he says, "Ladies and gentlemen, I'd like you to all stand up." For a minute's silence. The shuttle just exploded. Everyone died. That's the first lady was going to space. She was killed as a teacher, I think McAuliffe or something like that. So we all stood up, and it's memorable because of that feeling that you got. The next morning, I caught up with the speaker, and I had breakfast on the grass watching the whales tip its tails over in the big island of Hawaii. And this guy who's from Texas, he says, "Well, Tom, what are you doing?" And we had just finished our first patients on triple therapy for Helicobacter. This is 86, mind you, and we followed them up for 37 months. And I said, "I'll be reporting at Digestive Diseases Week," which was then called AGA, American Conference of Gastroenterologists. And I brought the abstract submission. We got people who are cured of ulcers now. He says, "That's a lot of hogwash, you know. Is that a copy for me?" I gave him the copy. Little did I know, 5 years later, he confided that he had an ulcer, treated himself, proved to himself that the ulcer went away for good. And we have a quote with Jackie, you just need one Martian to prove there is life on Mars. You just need your ulcer cured to know that it cures ulcers.
Well,
Because
I
they're
have to
double blind,
say,
you're blind and the ulcer is blind.
your protocol saved me on the 3rd of January 2021. It was a very memorable day. I had severe visual disturbances, but I could
Pros.
One of the things in Africa is our language structure in Africa, in terms of the Black languages, is very much to do with storytelling. So people will always say, "I hear," rather than "I see." And it's been a wonderful story to hear the story of Helicobacter, and hopefully with what our collaboration is doing between Zimbabwe and Australia, there will be another story that comes out of that on triple and quadruple therapy. But as we need to be cryptic and mysterious, we will say, watch this space. And let's see if a Martian lands to prove there's life on Mars. Thank you, Tom.
Thank you very much, and my honor to be here. Honored to be here.
Right, can you stop? Thank you, everyone. I hope you enjoyed that recording. I'm looking at the time, it's 1925. Dr. Nasser Syed is on the call, and he's a co-host. Nasser, can you just unmute your mic and introduce yourself?
Hi, Jackie. Good evening.
Hi, Nasser. I'm excellent. So NASA, in my limited experience, is a TB expert. And I think your question on the rifabutins, rifapentins, rifamycins has been answered, but I'd love to hear your comments, particularly when it comes to your use of moxifloxacin and was it rifabutin that you used?
No, we were using rifapentin.
Rifapentin. So I think your question's been answered about why we must not
Yes,
use
I'm very happy, and I'm very happy that I think in our last discussion I did raise this point with you that the TB guys don't like their medicines to be used in any other cases other than TB. They are very particular about especially rifampicin
And
group.
I think the message is clear. So quadruple therapy for Africa would be bismuth subsalicylate, tetracycline hydrochloride, 250 milligrams QDS, 40 to 60 milligrams of omeprazole as an antimicrobial 4 times a day for 14 days, and tinidazole 250 milligrams QDS for 14 days. Now, working in Mbari, what do you think of that as a regime? And should we be proposing this as a trial to the National Institute of Health Research?
No, I would be very, very honored because this is a very important regime because we have been using the previous regime which have been there, Pilokit and Pilobact to name some, and we were using a bit lower doses of amoxicillin and metronidazole and tinidazole. This is definitely is would be a little bit heavy doses, but I think the results should be good. So I think we will be very happy to part of a trial.
Perfect. Well, thank you very much for your opinion. There are so many questions that have come in on direct message and on the chat. What I think I'm going to do is I think we should end the call now because once we go over an hour, I think a lot of people are struggling with the load. I will put all the questions onto a sheet. Professor Barodi can answer them and we'll circulate it on the SADC group. And I think I would ask Obi to close now. I'm aware of all the questions. The only one that I can answer definitively is that esomeprazole is a isomer of omeprazole, so there's no reason that it wouldn't work the same way. And so the rest of the questions I'm going to pose to Professor Barodi. He has not come on the call yet, but it is 4:30 in the morning in Sydney. So, and I know he went to bed after midnight his time. So I'm not going to wake him up. I'm very, very grateful that he let us play this recording a week earlier than expected. Dr. Chavis couldn't present tonight, so he will present next week. And this was such an interesting discussion. I think that we should have further discussions on combination therapy with him. And I think we should pose all those questions at the end of that. I am aware that we have 1 minute to go before it's 7:30. And Obi, would you like to close?
Good evening, Dr. Jackie. Good evening, colleagues. Thank you very much for having that presentation with Prof. Barodi. Colleagues, yeah, as Jackie indicated, we've just about exceeded our intended hour for the session. Just a kind reminder, if you can please refer to the attendance link to enable yourselves to complete the attendance details. Any details that are not recorded on that link will result in us not being able to circulate your certificate for this session. So if you can please refer to the link, that link will be posted again on the chat. It has been posted throughout the hour on the chat. Secondly, Dr. Jackie,
I can't find it.
And Dr. Jackie, I note that there are, I think, 5 questions on the chat. Those will be collated and then circulated through you to Prof. Barodi. Colleagues, Dr. Jackie has expressed how we will then get those points responded to. Once again, thank you very much for joining us for another session, CPD session. We look forward to hosting you again next week, Wednesday, 6:30 sharp. The link to the session for next week will be circulated in the group as well. Once you've completed your attendance details, please feel free to exit the chat. A very good evening.